All right, everybody, welcome. Good morning. Matter of fact, a beautiful morning. My name is Isman Niazi, and it is my absolute honor to introduce my fellow co-chief and dear friend, Dr. Nikhil Nadkarni. Born in the burbs of Chicago, he moved as a young bull to the best coast, specifically Silicon Valley. He then attended the University of California, San Diego, where he graduated cum laude with a Bachelor's of Science in Biology and a Bachelor's of Arts in Philosophy. To no one's surprise, he was named Outstanding Graduating Senior of the Year. It was then that Dr. Nadkarni entered into an institution he has yet to leave. He completed medical school here at UCLA's David Geffen School of Medicine. He completed his adult psychiatric residency here at UCLA, where he served as the West Los Angeles Veteran Affairs Hospital ER chief. He continues to show his Bruin pride here in the fellowship, where he serves as a program chief. For those doing the math, that's 9 years here at UCLA. Silicon Valley's influence on Dr. Nadkarni is undeniable. In fact, Nikhil is kind of famous around here for creating academy quality videos. And more so, following the completion of fellowship, he will be taking the lead position for a telepsychiatry startup called Health Piper, which utilizes an app-based platform to expand access to quality psychiatric care for children and adults. And lastly, he's the man who introduced me to virtual reality video games. And I know I'm not the only one listening who can say that. Nikhil, we're gonna need to see that disclosure slide, man. So I was overjoyed to learn his Grand Rounds presentation today will be focused on the exciting possibilities that virtual reality can present to our beloved field, child and adolescent psychiatry. For those who are joining us today, please know you can type in questions in the Q&A section at any time during this presentation. They will be answered at the end in our discussion with Dr. Nadkarni and Dr. Bullock. And please remember to fill out an evaluation for attendance credit and for feedback to Dr. Nadkarni. With that, UCLA family, please give a warm virtual welcome to Mr. UCLA himself, Dr. Nikhil Nadkarni.
Thanks, Isma. That was the best intro I could possibly imagine. So thank you so much for that. I want to thank everyone for joining me for this talk. I think it's for some of you, it's a topic that you might not have heard very much about yet. And for others, it's a topic that you might have some personal experience with if you're an early adopter of technology and gadgets like I am. But no matter what your level of experience is, I hope you'll come out having learned something new from this field. I also want to note that I'm honored to be joined today by Dr. Kim Bullock, who is from Stanford and has really been a pioneer in this field and has mentored me through this process of learning more about how VR might be applied in our field. So I'm really thankful that she, for her guidance and for her joining us, especially in the Q&A discussion part after. But with that being said, I think we're ready to get started. So I will share my screen. There we go. Like as mentioned, my talk is going to be about virtual reality in child and adolescent psychiatry. To start off, I'll talk to you a little bit about what the objectives are. And so the objectives are kind of like a roadmap for the topics that I'll be discussing today. Initially, we're going to talk about the foundation, just by establishing what the definitions are of some of these terms that might be unfamiliar to you. Then we'll talk about the technology and how it's progressed over the last several decades. We'll talk about different ways in which VR has been applied in medicine, in other areas of medicine, to give you a sense of what is possible and what some of our colleagues in other fields are doing for innovation. And then we'll spend the bulk of our talk talking about virtual reality and its applications in child psychiatry. And really the talk is not meant to tell you, about the research in the field necessarily, but really to emphasize the possibilities, because this is still a field that is in its infancy, and it's not a field that has a very robust research base yet. But my hope is that as people get more interested in this and learn more, then we can build up that research base and learn more about how this technology might be utilized. And then finally, the last bit is going to be about the future in terms of the different directions that this technology might take. So the next thing is to talk about financial disclosures. So I don't have any direct financial disclosures. Nobody's paying me to give this talk, but I did want to make a disclaimer that throughout the talk, I am going to be referencing different technology companies and products to give some background on the history. It's very hard to talk about how this field emerged without, at least referencing some of the tech giants that have put in billions of dollars into this field to make it what it is today. So I'll be discussing some of those names. The descriptions that I'm going to be giving are not endorsements of any specific companies, products, or devices. But if you are interested in my thoughts on those things, I'd be happy to talk to you about that informally offline. But throughout the talk, I'm just going to be making some references to these companies. I think one thing that I always like when other people give talks is when they tell us why it's personal to them. And this is a topic that actually is pretty personal to me when it comes to my own life. So as Ismat mentioned, I grew up in Silicon Valley from age 10 onwards. And both my parents are software engineers and entrepreneurs. So our conversations around the dinner table were about doing which things. My dad, who I think is in attendance today, is an expert in artificial intelligence. My mom is an expert in the Internet of Things, and my sister is a solutions architect at Amazon. Don't ask me what that means. I don't actually know. But me being the fourth person who's not in tech, it's kind of safe to say that I'm a bit of an outcast compared to everybody else in my family. But their influence and their focus on technological innovation has really influenced me, and it's persisted within me. I studied, as Ismat mentioned, I studied philosophy and technology at UC San Diego. I got my first virtual reality device in 2015 when Google released the Google Cardboard, which was essentially a way to turn an old Amazon box into a fully functioning virtual reality device. And I actually built my own, and you essentially just insert your phone into this cardboard box with some lenses, and you're able to have a functioning VR device. And I just thought it was so cool that was a possibility. And so that got me interested in the topic, and I've had a couple of different VR devices since then. But my interest in VR has kind of gone along parallel with my psychiatric training over the last 5 years or so. And so as I've learned more about our field, I've also considered the possibility of implementing virtual reality technology in our field. Also, as Ismat mentioned, I've made a habit of introducing a lot of friends, family, and colleagues to virtual reality as a way for them to connect and play games, exercise, experience the world from home. And I think it would be a mistake to not mention, the influence that the COVID-19 pandemic has also had, both on this field, but also on me in particular. I'm humbled to be giving this presentation, on the cusp of the 1-year anniversary of our department's transition to telehealth, because many of the concepts that I'm going to be discussing today will actually relate to changes that have happened, through this difficult past year. And kind of strangely enough, the COVID-19 pandemic has influenced how I think about this technology in a lot of different ways. The first, on a personal level, it's allowed me to connect with my family at a distance. I can play a game of racquetball with my dad, even though he's hundreds of miles away, and still be talking and seeing and interacting with him as if he was standing next to me. And that's a very powerful feeling in this time of social distance. We haven't been able to travel, which is something that me and my wife really love to do. And so both of us have VR headsets, and we can sometimes, when we're tired of being within these four walls, we will virtually travel to a different country using the Google Street View data, which allows you to walk through a city or a country wherever you want in the world, and feel like you're there together. Then without access to gyms, this technology has made it easier for me to make home exercise fun and engaging, allowing me to get a good cardiac workout without, with an instructor in some of the most beautiful places in the world, without ever leaving my office. So these are just a couple of different ways that this technology has touched my life in the past year. And I'd imagine for many of you who have experienced this, you might have similar stories. But with that being said, I think it's important to talk about, what is this technology? What does it mean? And so I'll be going through some of the core definitions of what relates to virtual reality. So first, simply, when most people think about VR, they're probably thinking about it as a gaming technology, or imagining kids playing first-person shooters or something like that. But that's only a very small part of what VR can really be. A virtual reality is a simulation of a 3D environment that a person can interact with in a seemingly realistic way. The photo here is of a VR device called the Oculus Quest, which is produced by Facebook. Currently most VR systems look like this, where they have a head-mounted display that goes over the eyes with a strap that holds it on. And many of them will also have hand controllers with 6 degrees of freedom, allowing for you to move through the space. They also have buttons all around, so they allow you to simulate pointing or grip or other ways of interacting with things in your environment. So they have several different types of sensory inputs that I'll be talking about later on. But virtual reality needs to be distinguished from its kind of sister technology, which is augmented reality. And augmented reality is something that I'd imagine many of you are familiar with, just because of the phenomenon from about 5 years ago of Pokemon Go. Augmented reality is an enhanced version of reality that uses an overlay of digital information on top of an image of something real. So you're adding to what you're seeing in the environment. And that's perhaps why Pokemon Go was such a dramatic commercial success, with over 600 million unique installations and $4.2 billion generated from in-game purchases. Take a second to take that number in. $4.2 billion from a free game due to in-game purchases. It's really remarkable. And I think it speaks to the power of VR, in that the ability to take these like fun, lovable characters like Pikachu that people had some sort of connection to, and be able to put them in the real world, put them into the world that they're interacting with, was really powerful for people. And we all know what the craze was like 5 years ago, and many people are still playing this game today. So that just speaks to the potential possibility. VR and AR, while they're separate technologies, they are related, and their future is intertwined moving forward. The companies that are getting involved in these things are even developing technology that might be combined VR and AR. And we'll talk about that a little bit later. But I think a discussion of virtual reality or augmented reality is really incomplete without discussing this idea of presence. And whether you've heard this term or not, it's something that you certainly are intuitively familiar with, in that presence, the sense of being there, or that can be generated with hyper-realistic sensory stimuli, is something that we're all lacking right now. I'd like to be giving this presentation in person. I'd like to be able to see all your smiling faces. But unfortunately, because we have to do things over Zoom, that's not a possibility. And the idea of presence is something that we've all noticed is missing when we talk about things like Zoom fatigue, or how difficult this past year has been. being present in a experience allows for full immersion, especially with a virtual reality experience. Anybody who has tried the most recent sophisticated VR systems can probably attest to the experience of putting it on and then forgetting that you're in a virtual environment, or forgetting, having to remove the headset and being surprised that you're back in the real world. There's countless YouTube videos depicting that exact phenomenon. And I wanted to talk about Zoom fatigue here too, because I think this is an area in which virtual reality might be able to improve upon the way that we've been doing telehealth for the past year or so. And our very own Dr. Jenna Lee wrote a really fascinating article in the Psychiatric Times last year, where she examined many of the different neuropsychiatric factors that relate to Zoom fatigue. And I've included a couple of them here. She talked about decreased social rewards that occur in these two-dimensional teleconferencing interactions. She talked about the lack of nonverbal communication, how we can't, you can see my hands gesturing a little bit, but it's pretty limited compared to the full body experience that you might get if you were actually interacting with a person's full body and not just their upper torso. And then the sedentary nature of telemedicine interactions, how, when we are in clinic, we are in person, we are moving around, we are talking, there's an energy to it that seems to be lacking when we do Zoom and we sit in the same chair all day. And I think all of these different factors and many more are things that could be improved in a virtual reality space. And so to me, this begs the question, if we had the infrastructure to be doing virtual reality appointments, might we have experienced this presence a little bit more significantly, and maybe Zoom fatigue would not have been as much of a problem as it has been over the past year. But now that we've talked about the definitions and you at least have a preliminary sense of what this technology is, I'd like to go through the history of it so you can see how this technology has progressed over the last several decades. So first, we'll go all the way back to 1962 with Morton Hellig's Sensorama. So Morton Hellig was a cinematographer, and he created this entertainment device that was actually fairly sophisticated for its time, that was basically small films that had different sensory stimuli to accompany them. So there was riding a bicycle through New York, and there would be a fan blowing the wind in your face, and you'd be able to see the view, and you would have the sounds of the street playing for you. He actually even took it a step further and had smells that were chemicals that were released by this device into the system. There wasn't anything for taste, because I'd imagine people would not want to lick something inside of a device like this. But this is just kind of the first iteration of a virtual reality device. Then moving forward a couple of decades, the original iPhone made by a lab called VPL is the first time that virtual reality started to resemble what we see today. They beat Apple to the punch, I guess, with the name, but the quality of these devices was very limited. Computing power was a fraction of what it is today. And so these devices were clunky, extremely expensive, and weren't really able to create very sophisticated environments, though it is important to note that this is kind of the precursor to the types of virtual reality experiences that we have now. So it was a really important innovation. Even Nintendo got involved in this process of trying to get virtual reality into the mainstream. In 1995, they released the Virtual Boy, which was pretty much a commercial failure. It only lasted for about a year. It was clunky and uncomfortable. And it wasn't until 20 years later, with the release of the Nintendo Labo device, that they were able to successfully enter into the area of virtual reality. In the 2010s is really where virtual reality started to take off. And so the company that is probably most responsible for it taking off was originally a crowd-funded company called Oculus, and they raised an impressive $2.4 million in 2012, only to greatly surpass that by almost 1,000-fold when they were purchased 2 years later by Facebook for $2.3 billion. This was a step forward because this was the first sophisticated VR. It really simulated the movement and experience really well with eye tracking and things like that. And so it did have some drawbacks. It was very expensive. You needed to connect it to a high-powered PC, which meant that there was a significant barrier to physical movement, but also to utilization, because you'd have to have this expensive PC before you're even able to do it. And it was really seen and marketed purely as a gaming device rather than for any other purposes. This was my first foray into virtual reality. As I mentioned before, this is the Google Cardboard. You can purchase this directly from them, or you can make it yourself with a couple of household materials, which is what I ended up doing the very first time. And as you can see in the front, there's a little slot for you to insert a cell phone that basically serves as the VR screen. So this was also an important year because this is when, as I mentioned before, Facebook made this huge contribution that solidified VR as something that's going to be a part of the future when they, first invested this amount of money. Then, it took, Oculus has had several different iterations over the last 5 years, but it wasn't until 2019 that many of the barriers to getting VR accessible to the masses were broken down. And that was with the device that I had mentioned earlier called the Oculus Quest. The nice things about this device are that there's no other device needed. It's all self-contained within the headset. It's fairly high quality with a high processing power. It's portable. You can bring it anywhere. You can use it anywhere. It's more comfortable. It has visual feedback in the screen. It has auditory feedback that is based off of your positioning, which makes it feel realistic. It has tactile feedback in the form of vibrations within the controllers, and it has proprioceptive feedback because the headset knows where your head is positioned and it knows where your arms are positioned in relation, which all of these things together create a very strong sense of presence, a strong sense of immersion when people are using these. And perhaps the most important is that it was less expensive. It suddenly brought, there still is some sort of barrier to this. It's not as cheap as the Google Cardboard, but there is, this is bringing high quality VR to the masses without, needing a lot of additional support. I do think it's important to mention that this is not all, unicorns and rainbows. There's been a lot of controversy that could probably be its entire own talk surrounding Facebook and privacy and the requirement that these devices utilize Facebook accounts and that you're not able to use this device if you don't have a Facebook account. But that's kind of beyond the scope of what we're here to talk about. So now we've talked about the definitions, we've talked about the technology. I think what's really exciting is to see how this has been applied in different areas of medicine. And I'm talking about this to give you a sense of, the ways in which this technology has already been applied and maybe get those creative juices flowing for thinking about how it might be applied in our field. So one area that I'm really excited about for that VR has been utilized is in anatomy. And so those of us who are in the audience who have MDs will maybe fondly or less fondly remember the experience of being in the anatomy lab, which is fairly expensive to have these donated cadavers and maintain them and preserve them, make sure that you have that space. It's extremely expensive. When you are in medical school and you're doing your work on the cadaver, you have really limited anatomy. You're essentially focused on one body or another or two bodies, and you really only get to see what your body has. There are a lot of irreversible actions because as you dissect the body, you can't really undo things. When you cut something, it is cut and it remains that way. On top of that, the tissue is not living tissue, so you're not really getting the full appropriate experience that you might if you were working with a real body. Obviously, it's not possible to be doing dissections of real bodies. The other thing that I think people might remember is that it smells really bad. The formaldehyde is something that medical students really commonly complain about. And so VR has kind of jumped into this field. This is an example of an application of VR anatomy called Organon that came out a couple years ago. And if we compare that to the cadaver lab, it's much cheaper. We have unlimited anatomy. You can look at any part of the body whenever you want, and you can look at all kinds of shapes and sizes of different people. You can simulate live tissue, which is a really powerful experience. If you were able to zoom into the thoracic cavity and see how the heart beats and see how the lungs inflate and see how those two things happen together, that's something that you'd never really be able to recreate in a cadaver lab. And it's something that is really powerful for medical students to understand if these, if we can make accurate simulations there. We have an undo button. So if you cut the vagus nerve in your virtual anatomy session, you can always just go back and uncut it, which is not something that you can do in the cadaver lab. And then of course, my favorite part about this is that it smells like home. It smells like wherever you are when you use it instead of formaldehyde. Another, very similar example is the use of medical simulations. And so the traditional simulation labs are used to run a number of sims, including responding to stressful situations, performing different procedures, making diagnoses. The traditional model, just across the street from UCLA Ronald Reagan, there's an underground simulation lab in which different specialties will do all of these types of tasks and are very commonly competing for time. These are done traditionally with robots that are very expensive, hundreds of thousands of dollars, or with paid actors who learn a role and then the students interact with them. This time is very limited. It's expensive. You have to pay the actors, you have to pay for the equipment, you have to pay for the people to maintain the equipment. And you can, as you can imagine, a VR simulation where you can run these diagnostics, or you could practice procedures at home, could be a really significant way of expanding the way that we run these types of simulations in the same way that it was with studying anatomy. If we consider our colleagues just across town, this has been used in the pediatric population for pain management. And so I have a short video from CHLA depicting how they've been using it.
We've been using virtual reality initially in phlebotomy, which is where the kids come routinely for outpatient blood draw. And we're using it in a randomized controlled trial. And what we do is we engage the child in a fun, playful game. It's called Bear Blast. This is a game that we are collaborating with Applied VR to develop and to validate a gaming environment that's going to decrease pain and anxiety. My understanding about why it works is that it really engages the brain biologically, so that the frontal lobes are actually inhibiting the signal that's coming in by shutting off the incoming pain signal at that spinal level, so that it never reaches the child's brain or perception or experience. We've had kids who've said things to us like, when are you going to do it? And we've already completed the blood draw while they were playing the virtual reality game. There are definitely times where they don't experience any pain or any discomfort or any knowledge of the fact that the blood draw is happening. To even think that maybe in someday kids might look forward to getting their blood draw because they get to play the virtual reality game would be a great goal for us.
So that's just an example of how this is being used, even in our own city. I think it's important to kind of also consider that the presence that people feel when they're in these experiences allows for distraction and allows for mediation of that pain signal. We've learned from our didactics in fellowship that pain signal is really modulated by attention and focus. And so if you're able to distract from that, as they did in this video, you can actually, significantly change the experience that a person has of that pain. And so you can imagine that this being used not just in phlebotomy, but in a number of different procedural interventions that might be painful. So with that being said, we've talked about VR in medicine now. The bulk of the remainder of the talk is going to be on how we might apply this in child and adolescent psychiatry. I'm going to go through a number of different reasons why this is particularly well suited for our field. And then we'll talk about the different diagnoses where work has been done on this. We'll talk about some of the obstacles, and then we'll discuss where the future lies for developing this technology further. So first, why us? Why should we be the ones who are doing this? And I think about this in terms of patient factors and treatment factors. So with regard to patient factors, we have this population of people that we work with that have grown up with the technology in their hands in a way that no other generation has. This is the generation, that grew up with smartphones and with tablets and with computer literacy in a way that nobody else has before. And so they use these devices just as naturally as they walk and talk, very intuitively. And so that is a strong pull for their utilization. Moreover, because VR has been marketed and has come into the mainstream as entertainment and gaming devices, when kids see these things, they immediately think, oh, this is fun, this is a game. They associate it with something positive and something that they enjoy. And so we might immediately have their buy-in in doing VR therapy as compared to other therapeutic modalities where a kid might feel like they're being dragged into something that isn't fun. The nice thing about VR for me is that it allows for creativity and imagination. There are literally endless possibilities for using this technology. And in our first year rotations as fellows at UCLA, especially in the ABC rotation, the partial hospital, we learned how to use games, art supplies, and the child's own creativity as ways to engage with them, in unique therapeutic ways. And so the possibilities in VR are endless. You can, draw a picture in 3 dimensions. You can create a structure with virtual Legos collaboratively. You could play an instrument with a kid, or you could play a sport with them. If you can think of it, it can probably be done in VR, and that allows for utilizing the kids' creativity in really unique ways. There also are experts that suggest that there are neurodevelopmental factors that make the VR environment more vivid and with a deeper sense of presence for children than for adults. And so that also, suggests that kids might respond to interventions that utilize virtual reality better than other patient populations. But it's not just about the patients, it's also about us. It's about the treatments that we provide and the diagnoses that we treat. And so, as you might imagine, our VR interventions are much more feasible in psychiatry than just about any other medical field. Surgery surgery and pain management have definitely been leaders in the area of VR. But as we've learned with telehealth over the past year, just about any of our therapeutic interventions can be translated to telehealth formats. And we've noticed in our department that we've been able to kind of pick up where we left off, even though we switched to telehealth. And that is likely to continue with VR telehealth as well. One could make the argument that every DSM-5 diagnosis can derive some benefit from a therapeutic modality that's possible in VR. So we could do supportive therapy, psychodynamic psychotherapy, CBT, habit reversal, exposure and response prevention, DBT, you name it, it can be done in VR potentially. And so that means that unlike other specialties that might have a really narrow or limited use of VR, maybe surgical simulations or pain management, distraction, we can use this technology across the board for just about everything that we do, which makes things really expansive and interesting. On top of that, we think about what the first line therapies are for kids in our field. With children, we tend to be more conservative with the use of psychotropic medications than we are in adult psychiatry or in primary care. And that means that many of the therapies that we would do in VR could actually be considered first line interventions as a comparison to the way that we treat adults, which tends to be a little bit more heavy on pharmacology. And so those are some of the factors for why us. But next, I'd like us to discuss, how we might be able to use this. And I've put a couple of different domains in which this has already been studied. But I really want to make the note here that we're not, I'm not doing this talk to review all of the scant literature on VR in these cases, but really it's more to kind of get your creative juices flowing and get you thinking about the possibilities of what could be. We don't have a lot of definitive studies of virtual reality in children that say that this is as good or better than alternatives that are out there. We just don't have that information yet. And my hope is by exposing you to this topic that we might be able to, start to move as a field towards that information more. This technology has only been around for, in a sophisticated way for the last few years. And it hasn't really been cost effective to use for labs in the past, until the past year or two. On top of that, with the pandemic, you can imagine doing studies with VR has been very difficult because of the potential infectious risk of, having multiple people use the head-mounted devices. And so like a lot of areas of study, there have been some limitations during the pandemic. But we can go directly into some of the disorders. So first, as you might imagine, anxiety disorders really lend themselves very well to virtual reality interventions. And some of the most popular commercial applications for recreation are actually essentially exposures. There's an app called Face Your Fears that allows people to stand at the top of a high building or have spiders come running at them. And these are very similar to the types of things that we do for exposures for those types of phobias. The nice thing about anxiety disorders in VR is that the treatment really needs to be tailored specifically to the person. And this technology really allows for that because you have endless customization. You might even be able to do exposures that aren't possible in real life. For example, if a kid has OCD and has, intrusive thoughts that they are going to hell, you can create an experience that is similar to that, that you wouldn't be able to create in real life and make it feel real and immersive. And you can get through that as opposed to the kind of standard of care, which is imaginal exposure, which might not be as true an experience for the child. So I have another video here from the University of Colorado.
The program is pretty new at CAPS. It is a virtual reality program, and we're using this technology with students to help them with their fears. A lot of those fears could be related to fear of flying, fear of public speaking, fear of spiders, different scenarios in which evoke a lot of anxiety for individuals. Clinicians have been using this to integrate exposure therapy for a lot of veterans with PTSD. I think it's really exciting that we now have the resources to be able to use it within our counseling center, and so students have access to it as well. I really love doing exposure work with clients and being able to have them move through their fears. And sometimes when you are doing exposure, you don't have access to the things in the real world. And so the VR program really allows you to do that.
So with that, now I'll move on to autism spectrum disorder. So I looked at a systematic review of use of virtual reality in kids with autism. And this is actually one of the few areas where I did find a fair number of studies. But the focus of this slide is not to talk about the results of that because it wasn't very conclusive to establish that this treatment improves upon the standard of care. But rather, there was this chart from the study that I think is important because it shows what the focus was of many of the studies. There were 31 studies that were included in this of kids with autism and the ways that this technology was applied. So as you can see, most commonly it was for social skills and emotional skills, but then there's also daily activities, and then communication ability, attention, physical activity, phobias, and fears. And if you look at this list of what the studies focused on, you can also see that this is not just applicable to autism. This is something that is applicable to many of the different diagnoses that we treat in child and adolescent psychiatry. And the data isn't there yet to say that this is the right intervention necessarily, but there is so much potential for us to explore this further. Then eating disorders, is definitely also an important area that we all learn about, rotating on the eating disorders inpatient unit as fellows. And we learn just how sticky and how difficult these disorders can be, with only 50% of those who get evidence-based care showing remission, and then 24% dropping out before completion of treatment. So if we were able to have treatments that could keep kids engaged, keep kids staying in the treatment, then we might be able to have better outcomes. I'm referencing a study or a Viewpoints article that was written by a group of which Dr. Bullock was a member, that discussed the use of virtual reality Q exposure therapy, or VRCET, which is essentially a repeated exposure to these emotionally charged situations that you can recreate in VR, that typically might result in maladaptive eating behaviors like binging, purging, avoidance, things like that. And these scenarios are really customizable in the same way that we've discussed before. And so this is something that could really be beneficial for working with kids with eating disorders. Next, ADHD is one of our classic child and adolescent psychiatry diagnoses. I looked at a systematic review that did have a couple of randomized controlled trials included, and did have some conclusions that using VR-based interventions did improve in some cognitive tasks like sustained vigilance, in which kids would play a game and try not to miss things, and they had less omissions in these interactions. As I stated with the slide with autism, there are potential uses in social skills building, improving sustained attention. And I thought it was kind of an interesting use as well of pedestrian simulations. So instead of teaching kids how to cross the street safely using this technology, instead of having to do it in the real world where they might get injured. So we've talked about some of the diagnoses. There's, like I said, this could be used in a number of other things. But I think it's also really important to emphasize and talk about what are the things that can go wrong, because no intervention that we use is perfectly free of side effects. And so the first one is one that I'm sure many of you thought about already, the idea of gaming addiction, which is already a problem pre-VR. Rates in North America as high as 5% in some studies. Korea having the peak of 13% of adolescents experiencing overdependence on online gaming. The presence that people feel and the increased engagement that has been suggested in kids may go too far. It may be something that makes them to release. There's always that possibility that during the that kids might enjoy doing the exposures, but have a hard time transitioning from the exposures to the real world, and have kind of a failure to launch when it comes to applying these skills in the real world. Then, of course, we have the same access problems with virtual reality that we do with many other areas of telehealth, plus some additional unique ones. The cost can be low, as with Google Cardboard that I showed you earlier. And it is nice that every phone is a potential device, which might lower some of the burdens to receiving care. But we have to keep in mind that it's still, there are still limited resources for some people. Some people don't have the internet capabilities to be able to utilize these devices effectively. Even in a city like Los Angeles, where square footage is very expensive, even just the 6x6 space that you need to use some of these applications can be hard to come by. Visual ability is generally needed to be able to utilize these. And for some people, using glasses with these devices is difficult or challenging. And then, of course, whenever we're thinking about problems of access, we always have to think about how socioeconomic factors might and other factors might disproportionately disadvantage minorities and underserved populations. That's something that we've always got to be thinking about. Then, there's also this idea of cyber sickness, which is, for those of you who have tried VR, you might have experienced this before, where you might feel dizzy or motion sick, which we think is a sensory conflict between the visual inputs that you're getting from the screen and your vestibular system having different inputs. They did a comparative study of cyber sickness from VR versus classic motion sickness, and found that many of the physiological manifestations are very similar. So people who generally suffer from classic motion sickness might also be those who would be predisposed to having cyber sickness, though at least anecdotally, I have seen that just about anybody can experience this, but it is a small percentage of the population. Virtual reality headsets come with a warning that suggests that they should not be used in children under the age of 13, partially because of these types of concerns of visual strain, lucid dreaming, postural instability, headaches that do occur in a small portion of the population. But I challenge that suggestion because they did a study of young children ages 4 to 10 and looking for these types of symptoms, and basically found that young children fully tolerated VR gameplay without any notable changes or problems in any of these domains. But beyond the sickness that a patient might experience, there's also clinician challenges. Telehealth is still new. We're still in this crisis mode, and things will be different when we are on the other side of the river. VR training is basically unavailable. And it may take VR to be implemented more in medical education before it can really be applied in a significant way. Many clinicians aren't even aware of this technology or the potential, which is why I'm giving this talk in the first place. And then the next thing is to talk about what's next for this technology. How can we implement this in the future? And it's first important to talk about what is going on in the field technologically. So between 2017 and 2019, there were an estimated 14 million VR and AR devices sold worldwide. And then in the subsequent year, 5.2 million more were sold during the pandemic year. And the forecast is that by 2025, there will be 43 million sold per year around the world, with expected growth compounded over the next 5 years of 53.1%. So it's really expanding very quickly. Apple is projected to throw their hat in the ring with a VR and AR device coming in 2022. And there has been speculation in a lot of kind of technologically minded communities about the use of augmented reality contact lenses as early as the 2030s. Moreover, we really do need to expand our research on this topic. Like, as I said, there isn't a lot of robust research on VR in general, but it has blown up recently. There's more than 10,000 studies now as compared to 700 20 years ago. The cost of using these devices is actually also significantly lower than it used to be in prior decades. What I've referenced here is a set of recommendations that was published by an international working group that includes Dr. Bullock, that talks about best practices in clinical VR trials, and includes questions of basically a structure for how we might expand VR in clinical practice. So it talks about content development, how to early testing, is it going to work, is it feasible, is it tolerable, and then render than alternatives. I'm looking at the time, we're just about to end. The last bit is that telehealth really is here to stay. Even experts have predicted that even after the pandemic is over, virtual care is inevitably going to expand and expand rapidly. Telehealth is projected to be the second largest use of networked immersive VR behind entertainment. And so if it's here, I question all of us, why not make it fun? Why not reduce the fatigue for the providers? Why not increase access and engagement for patients and make it enjoyable with a real sense of presence? And so with that, I have one little closing video that if I were doing this in person, I would have loved to have a VR demo. And since I'm not able to do that, I'm going to show you a prior demo that I did with permission from one of my previous attendings.
You're being recorded, Dr. Burns. This is going in our retreat video for sure.
Are you crying? Are you crying?
This is not real. It can't be real.
Are you okay?
Look at it.
You have to, Lindsay, you have to go to where she is.
Oh my god. There's no way I'm getting on this thing. I'm gonna die.
So I guess you were all kind of spared from me doing that to you in clinic. But with that, I've got my references up here, and we are ready for a Q&A. I want to again thank Dr. Kim Bullock for joining me. Ismat, I think you can take it away if you've got.
Nikhil, that was amazing, man. Thank you so much for putting together such a well thought presentation. Let's go into the Q&A section. And just briefly, I would like to introduce Dr. Kim Bullock. And honestly, if I read all her distinctions and achievements, we would be at 10:30. So we're going to keep it quick. And currently, she's appointed as the Clinical Associate Professor in the Department of Psychiatry and Behavioral Sciences within Stanford School of Medicine. She founded and directs the Stanford Neurobehavioral Clinic and the Virtual Reality and Immersive Technologies program and laboratory. And with this expertise, she speaks internationally and locally about VR and its promises. So we are so lucky to have her here today. I know we have some questions in the Q&A, but I wonder, as more questions come in, Dr. Bullock, could you kind of briefly share your experiences on starting the VR IT lab at Stanford?
Yeah, I got really excited, just like that video, about how real and immersive and evocative of emotion that these VR experiences can create. So I did a plank walk with Jeremy Balinson, has a lab on our campus, and I went there and walked on a plank, and then they had a pit that you jump into that's pretty far down, and I couldn't jump. I was too afraid, and I knew it was an illusion, and I couldn't do it. So it really convinced me of the power of VR. And I also was very interested in implicit bias and changing that, because a lot of our therapy, I'm a therapist at heart. I do DBT and groups and CBT, and I work with somatization disorder and sensory and motor symptoms and a lot of disuse syndromes. And so the idea of being able to change somebody's beliefs without having the frontal lobe involved is really important, simulating exposures. We did some motor reprogramming and mirror therapy to actually help decrease pain. So anyway, I just became a fan and then thought, well, we should incorporate this into our psychotherapy clinic. And I had a CBT clinic. And I just went upstairs. I didn't ask permission. I just went upstairs to the admin and said, could you make me a label that says virtual reality clinic? And I think we're the first psychiatric ambulatory VR clinic that there is, but I encourage everyone to go out and do that. There's no reason. It's super easy. And I can also talk about, if you want to just add it to a clinical practice, how super easy it is.
It's so cool. Thank you for sharing that. Maybe we can circle back to that second part that you presented, but I want to make sure we hit some of these questions, including from Dr. Gil Hoffman, who also gave props. Fascinating talk, Nikhil. Are these VR devices hackable? How might they be vulnerable to interference, privacy issues, or potentially traumatic experiences?
So it's a really great question, and I think these devices run operating systems just like any computer, are susceptible to viruses or interference in the same way that any technology is. And so with that, I think Dr. Hoffman brings up a really excellent point, which is we do have to be really mindful of what the potential harms are, not just of the physical manifestations of this of cyber sickness and things like that, but also the ways in which this might be manipulated or used in negative ways too. I mean, you can imagine that this could be utilized by people who have intent to harm or intent to radicalize or something like that, and those are things that could be really, really troubling. With the privacy issues, as I mentioned before. There are already quite a lot of privacy issues surrounding the use of these devices and how they have to be linked directly to a personal social media account. So I think that's also something that's in the realm of discussion right now and is being hotly debated in the public discourse. Dr. Bullock, I don't know if you have anything to add.
Yeah, I think you really have to do your homework and know what you're using and do it fully informed. So if you're using gaming devices, especially in research, often you can work with the vendors to get a private HIPAA compliant space. But that's why I would suggest using platforms that are for clinicians that have been approved and are HIPAA compliant, and there's some data behind it. So yeah, and I think it's just an open gaming device. If you're going to do that, you need to be super careful, and especially if you're going to be doing research. So do your homework, be fully informed.
We have another question from VJ Nadkarni, perhaps the OG Dr. Nadkarni, who also gave props. Greatly enjoyed the presentation. What capabilities do you envision in the future of VR for psychiatry as the technology evolves?
Thanks, Dad, for that question. So I think, the way I think about this is looking at the technology first. And so the projections for how this technology is going to change over the next 10 years, or something I briefly mentioned. Apple is supposed to come out with a combined helmet that next year that is essentially going to be, it's supposed to have augmented reality has a lot of, in the real world, has enormous potential, and it, creates a sense of immersion that is, you are in the real world. So it's not even that you're having a virtual space. So I think as that technology evolves, there are things like TV shows like Black Mirror that show contact lenses that can basically simulate augmented reality, which is technology that is feasible within our lifetime. And so those are ways in which we may start to interact with the world in the future. And with each step of those changes, the technology is going to happen much faster than our understanding and our ability to recognize the risks and that sort of thing. And so it'll be really important for researchers to be able to assess whether this technology is safe and appropriate before we start implementing these things in our field and in others.
Yeah, there's one more question from Dr. James McCracken, and it's kind of on these same lines. So I'm wondering if I can just insert it now. The intensity of emotion in the video you showed made me worry about how some individuals may be at risk of overreacting, blowing up a therapeutic alliance, and worsening fears. Any comments to that concern?
Yeah, definitely. Maybe I'll let Dr. Bullock field this one first.
Yeah, and in practice, when I'm using that, because I do a lot of exposures, yeah, you can sensitize people. And so you have to enter gradually, and you have to, use your clinical wisdom to do that, and, be checking on subjective units of distress. And sometimes you start with an experience like teaching relaxation in VR, so you don't get linked VR and the fear. So yeah, I think good point. You don't want to be over-engaged and get sensitized rather than desensitized to a stimulus.
Yeah, and to with the video that was being referenced to, that there was no sensitization process or anything like that. It was, kind of jumping into an application right away, and so I think that also kind of related to the intensity of emotion that was experienced. But I think it was in a fun way. I think it wasn't anything too traumatic, I don't think.
Mhm.
But I'm looking at the time, and it does seem like we're kind of over time, actually. So I just really want to thank Dr. Niazi for the great intro and for facilitating this discussion. Thank Dr. Bullock for joining me and mentoring me through this, and all of the attendees for coming and learning about this really interesting topic. So thanks, everybody.